When you look at the fixation arena, probably one of the best papers you'll see out there is by Dr. Taylor, and hopefully he'll enlighten us a little bit about how we should approach this. Dr. Taylor?
I'd just like to thank the Society for giving me the opportunity to come here and attempt to convince you against the routine use of mesh fixation in the laparoscopic inguinal hernia repairs. I'm going to use just 3 points in my argument. The first is pain. We'll go into that in a little bit more detail. This is probably the number one reason. We don't want to be harming our patients, and certainly hernias can cause pain, and frequently that's the reason for patients to present to us in the first place. So for them to then develop new pain as a result of our intervention would seem a little unsatisfactory. Cost is an issue, and we'll talk about that. But my final point is that there is now increasing evidence that fixation, at least routine fixation, is in fact unnecessary. Spiral tacks or staples are, as we saw in the initial questionnaire, still the most common method of fixation that we all use. There are other types, fibrin sealant, glues, sutures, but still tacks today remain the most common form of fixation, and that's, I guess, because they are readily applied, easy to use, and not messy. However, there are increasing reports of pain that's sharp, persistent, new, and well localized after patients have undergone a laparoscopic repair of their inguinal hernias. And there's often correlation when x-rays are performed between the position of a fixation tack and that symptom. What really does drive this home as a culprit is the reports of relief after that offending tack has been explanted. What we did to try and clarify this issue of pain in a more scientific way was to perform a prospective randomised trial which consisted of 500 TEP hernia repairs. These were done in 380 patients, and that provided us with a number of patients for whom bilateral repairs were done, and we looked at that subgroup for greater clarification. The patients were randomised to undergo a standard laparoscopic, totally extraperitoneal repair using polypropylene mesh. This was a rectangular piece of simple polypropylene mesh, 15 centimetres by 10 centimetres. The operation was identical in all respects except for the point of fixation. If the randomisation schedule indicated fixation, then fixation was performed. The usual areas of fixation where nerves may be encountered or vessels may be encountered were avoided in all cases. So we confined the use of tacks to those areas above the iliopubic tract and into Cooper's ligament, nothing in the inferolateral area at all. The patients were then re-examined by a separate and blinded surgeon at least 6 months later. Our working hypothesis was that if there was going to be an increase in the risk of recurrence, that increased risk of recurrence would declare itself early. We all know that mesh becomes incorporated into tissue with time, and therefore the recurrence should be an early phenomenon if it's related to not having tack fixation. To assess the pain, we borrowed the definitions from Dr. Cunningham, who has done a lot of work in this area in post-hernia repair pain, and we assessed the impact of that pain with its frequency and devised a scoring system. So this is how we assessed all of our patients as to their symptomatology following surgery. This is what we found. In the group with fixation, the 38% of patients reported a new discomfort in that side of where the repair was done, compared to 23% without fixation. This was highly significant. When we looked at the severity of the pain across the board, the more severe forms of pain, while diminishing in their prevalence, were certainly more seen in the fixated group. When we looked at that subgroup of patients for whom a bilateral repair was done, I mean, this is an interesting group of patients because they do really provide their own internal control. We asked them which side did they prefer, which was more comfortable, and there was a greater percentage, in fact 5 times greater likelihood, that the patient would indicate the untacked side being the more comfortable side. And remember, these are blinded patients and blinded observers. Now, there are alternative forms of fixation. I do acknowledge that the real issue here with fixation is the tacks, not the fixation. but the tacks are the most common ones we all use. The issues that of fibrin glue and absorbable tacks certainly have been developed to try and get around this problem, and there are a number of papers now in the literature that show reduced pain when these alternate forms of fixation are used as compared with our more common non-absorbable tack. Coming to cost, cost really is an issue. The fixation as a component of the repair is actually quite expensive, anywhere between $500 and $1,000 depending on the method used. Now, where this has implications is that we are already criticised for performing hernias laparoscopically as it is now. This fixation is contributing to even higher costs for that laparoscopic repair. And where this has the potential to cause clinical impact is it may limit the uptake of the technique in public hospitals, such as it has in the early years of laparoscopic repair in Australia, where that was not the repair that was performed widely in the public hospitals and therefore had teaching implications as well. Coming finally to the lack of need, the question of necessity. And if we go back to the original stopper procedure of 1973, this was an operation where fixation was not performed. The key features of this repair were a thorough dissection of the preperitoneal space and using a large piece of mesh. So the size of the mesh was important, as was the dissection. Fixation was not important. And one of the unique features that we have with the preperitoneal space that we have access to in the TEP repair is this sandwich effect. And certainly on collapsing of that preperitoneal space, then the peritoneum does come up and hug that mesh well. Now, this has been looked at to see if it can actually put some science into proving that the mesh doesn't move. And so Choi and others reported in surgical endoscopy a few years ago their series of 32 consecutive repairs where they placed the mesh, they deflated the space, they performed on-table hip flexion exercises, then went back into the space to see if the mesh had started to curl or fold or migrate in any way. And no mesh movement or folding was found. If we now look at the randomised trials, there are now, including our trial, there are 5 trials that have looked into this question of mesh fixation in extraperitoneal repairs. And they all vary between 6 months to 2 years of follow-up. And there's been no significant difference found in the risk of recurrence in any of those trials. There are a number of other papers emerging now that are individual retrospective series that are starting to attract large numbers, showing that this repair can be safely done with a low risk of recurrence. So I would argue to you all that mesh fixation is not required as a routine course of the repair of extraperitoneal hernias. The features, rather, that we should be focusing on are the complete reduction of the hernial sac. And this is very important, the second point, the full parietal of the cord structure. So those cord structures will flop against the pelvic side wall without that bowstringing effect, which means that we have to not only reduce the sac, but we have to really reduce the peritoneum well back so that the mesh that can be then laid on top of that, those cord structures and cover the defects will do so in a flat, well-positioned way. We also must avoid mesh that is too small. So I guess this third point is important, that the routine use of fixation would seem redundant, costly, and perhaps painful in the majority of our patients who have small to moderate-sized hernias. When we looked at our own series, 3/4 of all patients had hernial defects less than 2 centimetres in size, and that's, I guess, our common experience. And this is where, at that size defect, large pieces of mesh, 10 by 15 centimetre pieces of mesh, are so much larger than the defects that we're covering that we have that flexibility for the issues of mesh contraction that we talked about before. Where we have to be more careful is where defects become very large. So those massive inguinal-scrotal hernias or the very large direct hernias are areas where I would be considering the selective use of fixation to hold that mesh in place, albeit knowing that there are limitations to where we can place our tacks anyway. And as we heard from the last speaker, the issues often relate to the lack of the ability to fix the mesh infralaterally that can relate to that increased risk of hernia recurrence from that direction. Thank you.